Well, howdy YouTube family. It's Bold CRNA coming to you with another week's topic. This is our second part to last week's video talking about the cons of being a CRNA. I talk a lot about the pros and what's good about being a CRNA, but people have been asking me, tell a little bit more about the downsides. Be honest, get real with the candid truth of what I wish would be different about the anesthesia community and being a CRNA. So today is part two, let's get into it. So with this week's video, we're going to talk a little bit more about the professional practice and the politics of anesthesia, which is definitely a huge element of being a CRNA. So one of the first things commented about that was the politics is the worst aspect of being a CRNA. They say having to defend and advocate for my full practice from physician anesthesiologists. That was commented multiple times, and that is a very real issue with the career, and it is something that you will be going, if you go into this career field, you will be defending against your practice and your training and ability most of your career, it seems like. I mean, people who have been in the field for many, many decades have told me that it was this way back then, and the history of anesthesia has shown that pretty much ever since physician anesthesiologists and nurse anesthesiologists have existed, they have not gotten along very well. And it sounds like they're not going to get along for quite a long time. As long as money is involved, I don't think it's going to be a cohesive relationship politically. Another person commented the constant assault from MDAs that don't believe we should be allowed to do what we do. Another aspect of this, so you deal with certain people. I don't work with any people like this, at least they're not vocal about it, but there are certain workplaces, and especially online, even probably in this comment section, you may find people, and you definitely can find it in previous videos, comment sections, of online harassers who are either med students or residents. Rarely is it actually a practicing physician, but it's usually someone adjacent to that field who is desperate to insist that they are superior in some way and that CRNAs are inferior and that they shouldn't be allowed to practice and blah blah blah. So it's definitely something you will deal with, not so much in your everyday real life, at least not open and vocally about it, but definitely online you'll see it more. And in the political realm, when you're going to defend things at legislative levels, you will hear and see things that are absolutely ridiculous. Another aspect about our professional practice that someone says is the worst aspect of being a CRNA is the medical direction model. Now, you may have heard that word before, medical direction model. So that is a model where one physician anesthesiologist supervises 4 CRNAs, and they are required, if they're billing, it's a billing term for Medicare and Medicaid. Medical direction is a billing term. And so with that billing term, if you're going to bill Medicare and Medicaid for that model to get the maximum amount of money you can out of Medicare and Medicaid, you will have to obey all 7 TEFRA laws. And so the TEFRA laws mean that the physician anesthesiologist has to be there for the start of the case. They have to be there for the end of the case. They have to be available immediately for the high points of anything during the case that you need them for. They have to prescribe an anesthetic plan and do the pre-op. They have to manage the patient in PACU. Those are a handful of things. I think there's a couple others, but essentially it means you're going to be your anesthetic will be heavily involved as a team together, and almost no CRNA enjoys that model because it diminishes your role and it essentially takes away half of what you're licensed and trained to do, that you're trained in school to do. You do like half of it because the other half the physician anesthesiologist is required to do or to assist you doing in order for them to legally bill that model. So yeah, most people don't like that model, and thankfully I have seen that model going the way of the dinosaur more and more every year because it's actually the most costly. It costs the patient and the healthcare system the most amount of money. You're paying literally like 200% for the physician to be involved in the case, and each of the CRNAs is billing like 50% for each of the case out of the 4 people that are being supervised. And so it ends up just costing more money than necessary, and there's no evidence to show that it actually brings any value to the patient. The next commenter says, working in a medical direction model and dealing with overbearing MDAs, not using all of my skills to my fullest potential will definitely not work here long. Yeah, so that kind of goes into what I was just saying. Most CRNAs hate that model, will not work in it for long. They usually work in it as just if they are required to for like their family's close by and it was just the first job that they got that paid really well, but they're only working there temporarily till they go somewhere else. That's why a lot of these practices are just going the way of the dinosaur, because CRNAs just don't want to work in them. And you won't use your skills to your fullest potential, quite honestly. Like I said, you're really operating at about 50% capacity. And if you're a nurse, like a bedside nurse, and you're trying to figure out like, well, how does this work exactly? So imagine that you got hired into the ICU to work in the ICU as a nurse, but you were told you can't put in IVs unless your charge nurse is holding the cannula when you do it. You cannot do admission assessments on your patients. You can physically do a lot of the work that goes on with admission assessments, but someone else has to actually sign the assessment for you and submit it. You are not allowed to put in NG tubes. You cannot administer IV medications unless you call another nurse over and the other nurse like does it for you because they're like your nurse manager or something. It's just really ridiculous. It's very time consuming. It's a waste of the resources. So people really just don't like it. So if you were a nurse practicing like that, you would probably quit that job and go work somewhere else. Another commenter says tension from the MD-AA world. So I told you I was going to lump most of these themes all together, so that's why it seems like this is coming up over and over. It is an issue in the CRNA world, and so there are people who are vocal about it and they don't like it. AAs, if you don't know what that is, it's an anesthesiologist assistant, and they're people who have a bachelor's degree in whatever they want it to be, and then they have 2 years of master's training, and then they're allowed to assist an anesthesiologist in performing anesthetics. And sometimes people confuse them for CRNAs, but they're quite different, and they're not trained or licensed to practice on their own or full practice. So they are a lot of times used in the medical direction model, and that's what they're trained to do. And so there's tension in that world with MDs and AAs, and so people don't like it. Early mornings, that one comes back again. I'm not the only one, neither is the other commenter that does not like early mornings. That was in our last week's video too, about you're just gonna have to get up early. I mean, your work schedule usually as an anesthesia provider starts so early in the morning. I usually get up at 5:30, 5:45. If it's 6 a.m. that my alarm's set for, that is a late morning. I'm sleeping in and it's gonna be a good day. So it gets old doing that year after year. A lot of responsibility is another comment here. That's very accurate. It is a lot of responsibility. It's a lot of stress. It's hard to quite grasp how much responsibility you're taking on and how much you have on you that you are responsible for and required to know in the moment. And you realize a lot of times when you're practicing that if anything goes wrong or the surgeon does something even wrong, it's not even anything you did, but the surgeon does something wrong, or the patient's body is not healthy and it does something wrong, you are required to fix it no matter what it is. And if you don't, it's your responsibility. Like if the patient has a bad outcome, it's kind of held on you, like you should have somehow fixed it. And that is very, very hard. And that kind of just sits on you day to day all the time. You don't quite realize you're just walking around with that kind of tension on you, but you do, because at any given time, you could be thrown into a situation that could happen and you are expected to fix it. Next person, another theme of this is they say some days are stressful AF. And that's very true. You will definitely have days that will hit you really hard. And I mean, being an ICU nurse, I think that's part of the reason why it's important to be an ICU nurse before you go back for training in this, because being in the ICU, you've had days where it was stressful. You've had days where one patient is coding and the next patient over is doing bad too, and you're trying to hang things and they're deteriorating, and you're doing everything you can, and the families are crying, and the different specialists are arguing with each other, and they're talking about DNR status or not DNR status, and nutritionists are calling you, and X-rays calling you, and they want to send them for a CT, and there's just 100 things you're juggling, and you're stressed out. So you understand as an ICU nurse what it's like to have a stressful day. You will have those kind of days as a CRNA or an anesthesia provider in general. but I would say it's even more of a heightened, it's less of a juggling multiple different things at one time kind of thing. Like you're not juggling multiple patients and you're not leaving the room and going here and juggling CT and blah, blah, blah. You're really just focusing on like the one case that you're on, but it will have multiple things that can be going wrong with it, and the outcomes are fully on your responsibility. Whereas as a bedside nurse, there's a whole team, and there's ultimately the physician that you're going to be calling, and they're ultimately going to be responsible for intubating, securing airways, trying to get the patient back going again. Like that's their responsibility. And as a CRNA, it's now your responsibility, and you're it. The next comment on what's the worst thing about being a CRNA is stress. So again, there's that same thing coming back. It is stressful, guys. I'm not going to lie to you. There are, I'd say, 75-80% of your time is fairly like manageable, but there is going to be a decent amount of time that's going to be very high stress. Next thing is production pressure. So yeah, I mean, in the unit, you would deal with patients, maybe like transferring a patient out. I guess this is probably the best way I could equate this. Like maybe the nurse manager wants you to transfer one of your patients out because they want you to get a new patient in, and they want you to do this thing for that patient, or they want to make sure that all the Foleys get out at a certain time so that their infectious rates are down and stuff like that. You deal with that kind of production pressure. Oh yeah, and like patient satisfaction scores, you probably dealt with that a lot. But in anesthesia, it's different. You're not dealing with that kind of production pressure. It's more like get cases done, generate revenue for the hospital. Surgeries and things generate lots of money and revenue for the surgeons and for the hospital. You are required for those things to happen. And so you will be put into kind of a pressure of getting those done as fast as possible, like turning over cases as fast as possible, getting set up for your anesthetic for your next case, getting the patient woke up into the PACU and woke up quickly in PACU without nausea and vomiting and complications, and let them go home. And then, there's a lot of aspects of what you do that tie up other staff members if it's not done the best way. So yeah, you deal with production pressure on that level. And especially if you independently bill, like if you're 1099, or maybe you independently bill for your own cases that you're doing, like you will at some practices, your production pressure will actually probably come from internal, because you make more money the more cases you're doing. So you will also, just like the surgeon, want to produce more cases and get stuff done. So yeah, that can become a stressful element. I got this comment a couple times from people dealing with lots of personalities in the operating room or the OR setting. The OR has a lot of strong personalities. You will deal with very strong personality surgeons, of course. I mean, everyone assumes that you're going to have strong personality surgeons. But you would be surprised that there are other people who are not surgeons who also can have very strong personalities, and actually I've worked with some circulator nurses who will terrorize the surgeon and try and terrorize anesthesia and just like make the whole room disruptive and make the whole day just uncomfortable, and people are, on eggshells around them because they're just like a rattlesnake ready to snap all the time. That can really make a day not fun and enjoyable. And there are definitely types of nurses, like clipboard type nurses, who work in the ORs, who are very big on like checking making sure you're dotting every I and crossing every T, and they think it's their role to make sure everyone else is doing their job too, not just themselves doing their own jobs. So you will deal with those people in the OR. They do have strong personalities. They can be difficult. I'd say usually scrub techs and people like that are fine. They're not going to get too much, wild out there. But yeah, I would say there are some nurses who work in the perioperative period and in the OR setting that, some of them are my favorite, but there are definitely some that the surgeons don't want to deal with and anesthesia don't want to deal with. I'll just put it that way. Lack of public awareness about us and our full service anesthetic capability. Yeah, so this goes into explaining to people over and over who you are, what you do, what a CRNA is, what you can or what they think you can't do. Are you supervised? What does supervision mean? What does a billing term for supervision mean? Does that mean practice-wise you have to be supervised? Another person says very few downsides, but being stuck in a room with no windows for hours on end some days isn't great. I remember there's one certain room in a surgery center that I used to work in that had like a wrap. It was in the corner of the building and it had wraparound windows. And I used to be like, this is the best room. Even the surgeon would comment like, oh, I like this room. And the reason why is because we're human beings and we don't like feeling like we're trapped in a dungeon all the time. You want to see light, windows. You want to feel that sense of outside nature, especially when your job revolves around being in a very dark, usually in a basement type area all the time. Year after year after year, day after day, you want to be somewhere that's got light and windows. So it does kind of wear on you sometimes where you're just, especially if it's a long case, like long stretches of hours where you're just stuck in this 4-walled room with no windows and no light. And here's something that especially I would think you moms may be really drawn to, is that this person says not being a part of your kids' morning routines because you have to be at work early AF. So yeah, you have to be at work early. We've said that before. And one thing that plays into that is maybe you want to get ready with your kids in the morning. Maybe you want to make them breakfast or talk to them about their mornings or their upcoming day or what they're focusing on for school, or even maybe driving them to school and dropping them off and just having that kind of like parental connection with your kids. You're not really going to have that much as a CRNA. I mean, maybe you could find a way to work it somehow where you could work a practice where you worked later in the day. I'm just going to say 90% of the time you're going to be out there. You're just not going to get that because by the time your kids are even getting up for school, you're probably already in the OR. So you would have gotten up much earlier and be on your way and going. So you're going to miss a lot of that unless it's maybe an off day you took and then you're getting them up. But your normal routine is not going to be like getting ready with the kids in the morning. Everything is always anesthesia's fault. Reminds me of when we were bedside nurses. There's like a joke that everyone has about, oh, it's anesthesia's fault. Surgeons joke about it. Anesthesia jokes about it. We pick fun at it all the time. But it does kind of, the reality is, in the OR setting, when things go sideways or something's happening not good, there's usually two people to blame. It's either going to be the surgeon or anesthesia, and you can bet the surgeon's not going to be blaming themselves very much. There are some who will openly be like, oh yeah, that's my bad. But a lot of times it's somehow anesthesia's fault. And maybe it is. I mean, I'm not saying we don't ever have blame for anything, because sometimes it is our fault. But it's kind of comical when you'll be in a situation and you're dealing with something that definitely was not our fault, but the surgeon will try and imply that it was. And so there is this long-standing joke, which can be exhausting sometimes when you are in a real situation and someone is trying to blame you for something that really isn't, it's out of your control. This one I can definitely understand. They say it can feel like a lonely profession at times. It can. I mean, the reality is, especially if you come from bedside nursing, where it's like a team of people and you're all at the nurse's station, you're all charting and talking to each other and talking about your weekends and blah, 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 and running around and helping each other turn patients. And, if you need to grab something, they're going to help you, or you got this going on, they're going to help you, or whatever. That's not how anesthesia works. Anesthesia is a single person type thing. Like, you will have your patient that you go see and treat and do your thing for, go to the OR, you'll perform your anesthetic, you'll wake the patient up, you'll take them to the PACU, you'll do your next patient. You may only intermittently see other anesthesia providers in between cases, if even that. You might go a whole day barely speaking to anyone else on the anesthesia team. You will probably have a lot more social interaction with the surgeon and the in the circulator and the scrub tech than you will other people in anesthesia, because there's just one of you in a room at a time, and so you don't really interact with each other that much. So it can feel lonely. And sometimes in the OR, you pin your drapes up and you're kind of back away from everyone else, and it kind of puts a barrier between you and them, which I personally like most of the time. But the other aspect of that is it can feel lonely, because it's kind of like you're secluded, like you're putting a barrier wall up of communication from you. So unless you stand up and make visual eye contact with the surgeon and the scrub tech and the circulators, they usually assume you don't want to be bothered, and they don't usually talk to you. They usually carry on their conversations amongst each other, and you just do your own thing over here. So it can feel lonely sometimes. If you're someone who likes a lot of social interaction, I definitely know CRNAs who stand through most of the case and just talk and chit chat with everybody in the room. So you can be as social as you really want to be, but it can, unless you make the effort, feel lonely. Mental fatigue from intense shifts or cases. That goes back to the stress thing we were talking about earlier. It is stressful. There are definitely definitely days, most of the time when I leave work, that I'm just tired. Like even if I only worked 8 hours that day and I only worked 7 to 3 and I got off and I didn't even have that much crazy stuff go on in the OR or anything, I still just feel tired. And maybe that changes after you've been doing it, 8, 10, 20 years, and it just becomes secondhand nature to you and it doesn't really mentally fatigue you as much. But I will say, as someone in 2 years of practice or so, it is tiring. You just feel tired when you go home. The stress and the responsibility is definitely real, and you just feel tired, and you feel it up here even more so than your body. And the last negative thing about being a CRNA, and I'm gonna call Aisha CRNA out on this because I don't think she'll mind. She commented, "None, bye." And that is definitely an Aisha comment. She says there is no bad aspects about being a CRNA. She loves it. And there are definitely, I can have that attitude too sometimes, which is why I did this video series anyway, because so many people tell me that I talk about all the awesome stuff and I make it look so great and so glamorous and all this stuff, but I don't show a lot of the negative sides. So I thought, why don't we do a little bit of a video series that highlights what some of the nitty-gritty stuff that's maybe you don't know about, that you don't want to maybe deal with. Maybe it's part of a career thing that you just don't want to get involved in. If you heard stress, bad schedule, being on call, politics, you heard all those things and you said, you know what, I don't know if that's for me, then that's what this video's purpose was for. I don't want to deter you from your career, but I also don't want you to go into something blind, not understanding what the bad sides of being a CRNA is. I want to hear from you guys down below. If you didn't comment last week on the worst elements of the career that you've experienced or that you're afraid of, I want you to comment down below. Also, go and hit the like button, hit that subscribe button. It's really important for the YouTube algorithm. If you don't do those things, it doesn't recommend the video to other people, and then the channels don't grow, and then we just wither away. So go hit the like button. And join the mentorship. If you want to be in the membership and you want some mentorship and you want exclusive behind the scenes videos and you want to maybe do a mock interview with me to get into CRNA school or anything like that, or just want help and advice or one-on-one chatting, join the memberships. It's over here. Just click the tab. It's right there by the subscribe button, I believe. And join up at any level you want to be at, and I will be happy to have you guys over there. And until next time, that's Bolt out.